I don't know if y'all, obviously you should know, but if you don't know, Tina Turner recently left us. And technically this is a CCR song, but we'll do this one for Tina. Left a good job in the city, working for the man every night and day, and I never lost 1 minute of sleeping. Worry about the way that things might have been. Well, big wheels keep on turning, oh, primary keep on burning. Rolling, rolling, rolling on the river. Rolling, rolling, rolling on the river. Cleaned a lot of plates in Memphis, pumped a lot of pain down in New Orleans, but I never saw the good side of the city till I hitched a ride on a riverboat. Well, now big wheels keep on turning, whoa, primary keep on burning. Yes. Rolling, rolling, rolling on the river. Rolling, rolling, rolling on the river. And if you come down to the river, bet you're gonna find some people living. You don't have to worry, 'cause you have no money. People on the river are happy to give it. Big wheels keep on turning, whoa, primary keep on burning. Rolling, rolling, rolling on the river. Rolling, rolling, rolling on the river. And we're rolling, rolling, rolling on the river. And we're rolling, rolling, rolling on the river. Some CCRs, Tina Turner right there for you. They have a nice spread of food back there, which I will also be picking at some point. Thank y'all so much for coming in bright and early in the morning. I'm gonna play an original tune here next. This one is called Melody. Baby, know I love you when you drive me crazy. The way you move, that always just amazed me. I pray that things don't get too complicated. Jaded, faded, 'cause your touch keeping me high, you won't let me down. No gravity when I'm on the ground. Burning so hot, there's no cooling down, love. Your love is pure as the moon in the darkest night. Forever I'm yours. Oh. Na 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 na, na 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 na, na na na. Put it into overdrive, climbing up the mountainside. Feel take me higher, higher. Swimming through my deal more, and I dive into your ocean floor till I reach the bottom. Whoa, yeah, yeah, yeah. 'Cause I got the melody, you got the remedy. Come give me all of you, I'll give you all of me. I got the melody, and you know you got me, yeah. Oh, yeah, yeah. It's an original tune right there called Melody. Thank you. I want to take a moment to thank y'all for all that y'all do at Central Health. Make some noise for yourself. Come on. Come on. It's because of you that I could be up here in a healthy state. I actually didn't have access to health care for like 5 years. And this is my first time with him, actually. And to think that my mom was like, "You'll never get insurance as a musician." Haha, joke's on you, Mom. I now have insurance. No, but it really is a great thing that y'all are doing, and I know the rest of the music community feels the same. But it's a huge lifesaver for us to be able to have access to health care and to be able to do what we love every day. Y'all make that possible for us, so thank y'all for that. I'm going to cover a song by an Austin musician. Her name is Emily Wolfe. I don't know if you know of her, heard of her, but she is also a Ham member as well. But she has a song that I really love. It's called Vermilion Park. So this is a local Austin musician for you. The days of Vermilion Park, this is the dark, the rhythm on a side. Underneath the marquee, feeling that spark. Better go now, 'cause we're running out of time. I don't wanna rush you, babe. I don't wanna rush you, babe. Ooh, and only when the train comes, we can keep it on track. Comes and it goes all night long. I just can't get close enough to you. Shake my bones. You and I collide the avenues. Ooh, I'm living up with you. The days of Vermilion Park come back around, let me give you a ride. Don't you play it in the back of my car. Driving all night, we can cruise out for miles. So I don't wanna rush you, babe. I don't wanna rush you, babe. Ooh, and only when the train comes, we can keep it on track. Comes and it goes all night long. I just can't get close enough to you. Shake my bones. You and I collide the avenue. Ooh, I'm living up with you. I can't take it anymore. I can't take it anymore. That's what our hearts are for. That's what our hearts are for. I can't take it anymore. I can't take it anymore. That's what I'm dying for. All night long. I just can't get close enough to you. Shake my bones. You and I collide the avenues. All night long. You and I collide the avenues. Ooh, I'm living up with you. Some Emily Wolfe right there for you, local Austin musician. I play out here at a retirement home, so if you got folks out at Belmont Village, sometimes I play for your family. And here's a tune that I learned for them over there. I'm running down the road trying to loosen my load. Got 7 women on my mind. 4 they wanna own me, 2 they wanna stole me. One says she's a friend of mine. But take it easy, take it easy. Don't let the sound of your own ears drive you crazy. Light it up while you can. Don't even try. Just find a place and make your stand. Take it easy. And I'm standing on the corner in Winslow, Arizona. Such a fine sight to see. It's a girl, my lord, in a flatbed Ford, slowing down to take a look at me. Come on, baby, don't say no. Running down the road, trying to loosen my load. Got a world of trouble on my mind. Looking for a lover, won't blow my cover. Man, she's so hard to find. But take it easy, take it easy. Don't let the sound of your own ears make you crazy. Come on, baby, don't say no. Some Eagles for you right there. Thank you. Got a few more tunes here for you. And then they're going to tell you stuff. I'm not sure what. It's going to be a surprise for all of us. I don't know if you could tell by my high energy music that I typically play in the afternoon, evening times. So I hope you had your coffee this morning. I'll play one that's a little bit, like a little bit slower, but like, you know, it's like, is what it is. Here's some Fleetwood for you. Now here you go again, you say you want your freedom. Who am I to keep you down? It's only right that you should play the way you feel it. Listen carefully to the sound of your lonely Stillness like a heartbeat drives you late. Stillness of remembering what you had, what you lost, what you had, and what you lost. Thunder only happens when it's raining. Here I go again. I see your crystal visions. I keep my visions to myself. It's only me who wants to wrap around your dreams here. Have you any dreams you like to sell me? Dreams of loneliness like a heartbeat drives you mad. The stillness of remembering what you had, no, what you lost, baby, what you had, and what you lost. Oh, thunder only happens when it's raining. Players only love you when they're playing. Some Fleetwood right there for you. I got time for maybe one more song here. Do we want to do a cover or original? What are we feeling out there? I don't know why, but I'm just staring at you, so you have to give me an answer now. You're like, panic. Got him. Bright and early in the morning. It's like when the teacher in the class, and you're like, please don't look at me, teacher. I was always asleep, so it didn't bother me then. Or drawing on my arms. Now I have tattoos. That's the whole thing. I'm gonna end it here with this original tune. This one's called Kerosene. Thanks for having me, y'all. I hope y'all have a great rest of the morning with the events and the food in the back and the coffee and the whole nine. Here we go. Early in the morning, singled in my thoughts. Another restless night. Am I ever gonna find some sort of resolution to the spell you had me under? No, 'cause I can't help but feel memories that leak around of you. But let me up there, tricking me down, and I'm used up. No, want you over and under me, over again where you lie. Sweet, sweet, sweet kerosene, burning in my mind all the time. Is this a dream? 'Cause it ain't reality. Yeah, funny how the nights breathe. Standing and waiting at your door. just as patient as could be. I could drive, tell me where we're going, knuckles pale. The everlasting grip that you have on me. Can't you see? Memories still linger around of you. Then let me up, I'm tricking you down. We're all used up, no, but you're still on my mind tonight. Sweet, sweet, sweet kerosene, burning in my mind all the time. Whoa, it's a dream 'cause it ain't reality. Oh yeah, but ain't it funny how the night brings, yeah. Da-da-da-da-da. Whoa, feeling fever through the night. Girl, you're burning on my mind, and you're haunting me. There's your finger on the trigger. Oh, I lay down and surrender, 'cause you're on to me. Whoa, no, sweet, sweet, sweet kerosene. Oh, you're still burning in my mind all the time. Oh, when it's a dream, 'cause it ain't reality. Ain't it funny how the night brings? Yes, all of the memories. Yeah, all of the memories. Yeah, you turn the temperature high. The temperature high. I said, yeah. You have a great rest of y'all's day. My name is Kelsey Creek. Thank you so much for having me. And thank y'all for everything that y'all do. Really appreciate it. Thank y'all.
Good morning, everyone. Let's give another round of applause to Kelsey Creek. Thank you, Kelsey. She is with HAM, and we have a few HAM members and staff members here in the audience today, so thank you all so much for your support. Thanks so much for coming, and thanks everyone for being here this morning. I know it's bright and early, but we appreciate it, and we hope that you've helped yourself with some breakfast tacos, some fruit, and coffee, because we're going to have a really good conversation this morning. So without further ado, actually, before I do that, buenos días a todos. Muchísimas gracias por acompañarnos esta mañana. Va a haber, hay un poco de desayuno. Por favor, sírvanse. Hay tacos, hay fruta, hay café, jugo de naranja, así es que por favor, sírvanse. Muchísimas gracias de nuevo por acompañarnos, y si van a necesitar interpretación, les pido que por favor vayan a la mesa de atrás. Mi colega está así saludando y ahí hay audífonos. Entonces vamos a tener interpretación al español para que estén cómodos. Y por favor que no les dé pena. Así es que los que necesiten interpretación, por favor vayan allá con mi colega. Y si tienen algunas preguntas, por favor no duden en preguntarnos. All right, everyone. So without further ado, allow me to introduce you to our President and CEO, Mike Gieslin, who will do a welcome.
Thank you. Good morning, everybody. So my name is Mike Gieslin. I'm with Central Health, and we are the healthcare hospital district for Travis County, and we enroll over 100,000 persons plus each year in our medical access program. And today, we're going to share our work about building out a high-functioning safety net system, and that's who we are here in Travis County, and we could not be this without you all being here today. We don't go this alone. It's partners, it's community conversations, it's friends. Thank you for the prompt on the mic, appreciate it. Can you hear me now? Okay, good, thank you. What matters? So think about what matters to each of you, or perhaps people that you care for or know. If eliminating these disparities that disproportionately impact communities of color or by gender or orientation identities. If that matters to you, and I'm just answer this just inside for a minute. If it matters to you to fill gaps in the healthcare system, so to have greater access to appointments, or perhaps no appointments at all, because it's hard to make an appointment, especially for folks that we serve where transportation is a barrier and a challenge. Or maybe a gap could be being able to have time, not only just with a doctor, but with other specialists. So perhaps a nutritionist, somebody that works with you on the pharmaceuticals. Or perhaps it's a specialty care like nephrology or podiatry. If those things matter, then you're in a good and safe space today. Those things matter to us. And it's about overcoming the disparities. It's about filling the gaps in the healthcare system. And it is about helping people live their best and healthiest life possible. And that gets us to health equity. There's tons of definitions out there and ideas and thoughts on health equity. And is anyone wrong or anyone absolutely right? No, probably not. But that's okay. Because that's why we come here together today, to figure this out together. And so this is an amazing conversation, and we're going to hear about health equity and really what matters to people. And what brings us here today, to close out the welcome before I introduce Dr. Mullen, is we're here today because we started this journey back in 2022, and it was about information about our patients, but also by and from our patients, the people that we serve, their stories. And so maybe if that's what matters today, it's the stories that people tell, what they remember, you're in a good place too, and a safe space too. So to start us off, I'd like to introduce Dr. Jewel Mullen. She's not wearing 3 hats today, but she does wear 3 hats. She currently serves as the Director of Health Equity and Quality for Central Health, as well as a subject matter expert on our Medical Executive Board. She is the Associate Dean for Health Equity at Dell Medical School, as well as a professor in the Population Health and Internal Medicine departments. And she also serves as the Director of Health Equity for Ascension Seton. So please help me welcome Dr. Jewel Mullen.
Good morning. Mike, Mr. Giesland, thank you for the introduction. The notion of having on those 3 hats might make some of you think, with all of that on her head, she must have a really big headache. But I don't. Instead, I show up here today at the end of my 5th year in Austin, grateful. Grateful that you have let me be a part of this community in the way that you have. And particularly grateful for Central Health's including me in their work, because people will tell you there are many days when I say what I have chosen to do in wearing my hats, in spending so much time being included in the work that we're talking about today, has been some of the best and most joyous time in my 5 years. And I hope that as I tell you, what I have to think about healthcare safety nets, you'll understand that those are authentic statements that characterize who I was before I got here and who I'll always be. So with that, I think I'll just ask for the first slide. I'm going to talk a bit about my definition of safety nets, my experience working in safety net systems, some of what I see and others see as challenges to the safety net, and the opportunities that we have here before us in Travis County and beyond. As I do so, and I know I have a lot of slides, but many of them, like this one, are just as much pictures as they are words. And I hope that as I go through my talk, some of you will help put some words to the pictures. And that starts with, what I was asked to come and do, which was to talk about building a better healthcare safety net system. I told my husband I was going to give this talk, and he said, wow, you're going to do that? That's a huge topic. And I said, yeah, but there's not even really a single definition for safety net system, which means I actually get to choose what to talk about, but also that gives us all a chance to think about what it means when we talk about having a healthcare safety net system for people here in Travis County, and I'll say in Travis County and beyond. And safety net sounds so nice. It sounds like something in this picture, like, someone is there holding it, ready to catch you. You are safe. Wouldn't it be nice? One might also look at that picture and think some people are looking up saying, oh no, what's about to fall down here next, and how are we going to deal with it? Because that's also so much of what a safety net system has to do. It's not easy. You can help some of the people some of the time. You can please some of the people some of the time. And you often have to live with your own recognition that no matter what's in your heart, you can't do it all. And along the way, people will hold you accountable for not being able to do it all in a country that has not created the possibility to do it all for the people who need it most. So, warning, I might preach a little bit along the way. It's okay to go on to the next slide, thanks. So, we say safety net. Sometimes people are talking about safety net populations, and might be talking about people who are or underinsured, low income. That might include people who work 1 job, 2 jobs, or 3 jobs, even though for some it means, oh, those poor people, that bootstrap population. They exist in urban and rural areas. They're people with special health care needs. They're low-income people who have many other financial and other financial non-financial difficulties that make it hard for them to put health care and what they need as a priority. We can go on to the next slide. Sometimes we talk about safety net providers, the people who are caring for those populations that we just described. Thank you. Safety net provider, and I claim to have spent a lot of my career being a safety net internal medicine primary care doctor. Safety net providers often work in situations and organizations that are underfunded, that are tenuous, that are sometimes shut down. Think of the epidemic of rural hospital closures, and in some cities, urban safety net hospital closures. but they're also resilient, scrappy, resourceful, and get this, adept at gaining support through the political process. I've worked with safety net provider doctors, resident doctors in the past who went on strike, not for better wages, but for the ability to take better care of their patients. You don't see that kind of courage among many physicians anymore, even when they work in a safety net. And some people, you don't see that kind of courage. You want to see that kind of courage again, okay? We can go on to the next slide. And it's hard to think about the safety net healthcare system without thinking about how inextricably linked it is to the social safety net. Supplemental nutrition assistance, SSI, unemployment insurance, housing assistance, Head Start child care, job training, and even Medicaid and Medicare, all parts of the social safety net. And so we talk safety net as if it just all clocks along in ways that work together, but we all know that it's not quite so. So we can go on to the next slide. So since there's not a single definition of safety net health systems or hospital systems, I went back to one that's the Institute of Medicine coined back in 2000, at the turn of the century, which people still quote today as, and I'm sorry I'm looking over here, but I might pause for a moment when I ask you guys a question and pull up my slides in front of me. Describing safety net hospital or health systems as patchworks of hospitals, clinics, financing, and other programs, but they vary markedly. So you've seen one, you've seen one. They address minimally the basic healthcare needs of populations that are vulnerable. And their funding and organization have always been tenuous, subject to the changing tides of politics, available resources, and public policies. And that happens at the federal level, the state level, the county level, and the local level. So we can go on to the next slide. And so I want to claim that I have cred because I worked in the New York City and learned in the New York City Health and Hospitals Corporation system. It's the largest healthcare safety net system in the country. You might not be able to see the slide well, but that multiplicity of hospitals that are part of that system included Elmhurst Hospital, where I rotated through when I was a medical student, Harlem Hospital, where I worked in the emergency department between my second and third years of medical school, and I told my husband I would also say where I met my husband. Bellevue, where I was an attending doctor in a primary care clinic, a family care clinic staffed by internal medicine and pediatrics doctors, 2 social workers, a full-time sign language interpreter, 2 medical interpreters, a nutritionist, all as part of our clinic. In the New York City Health and Hospitals Corporation that worked very closely with the New York City Health Department and many other service agencies. And then, later in my career as the medical director of a federally qualified health center look-alike, Mason Square Health Center. But, I'm gonna tell a little bit about some of those experiences and how they inform what I do today. So we can go on to the next slide. Sure, yes. Did we miss a slide? Well, at least you know I know my slides. So, Harlem Hospital. I worked there, do the math, in the summer of 1979 for 2 months in the emergency department, July and August. Some of what I remember about Harlem Hospital additionally harkens back to right now, because many of the patients that we saw were brought in unresponsive. And the question sometimes, and oftentimes was, is it hyperthermia? Is this somebody who has suffered from extreme heat exposure in an apartment building with no air conditioning? Or is it a drug overdose, or might it be an infection? And in either circumstance, that passage into the emergency department was also our eye-opening into what else was going on in the lives of people who maybe most of the time we didn't think about the fact that they were in high-rise apartments baking and coming in with temperatures of 105, 106, 108 degrees and needing to be cooled carefully. But in hearing the weather report this morning, couldn't stop and think about being housed in a Texas prison right now and not having air conditioning. I'll keep going. At Bellevue, unlike Harlem Hospital, which was mostly a community hospital, Bellevue, we really took care of patients from all 5 of New York City's boroughs. I had patients who had recently arrived from Vietnam, from China, from Haiti, from many Caribbean countries, people who came in shackled from the jails. People who were deaf, most often because they had had childhood rubella and not been vaccinated. And so in all of those circumstances, you get to see the context of what it is like to work in a safety net system and know that what you can do as a healthcare provider, supported by a very robust hospital system, can still seem minuscule, but really important in the context of what everyone needs. And that was even the case when I had been at Elmhurst as a medical student, where we got lectures about severe maternal morbidity and preeclampsia, and where we coursed through the newborn intensive care unit and saw numbers of Black and brown premature infants who had been born very early, but never really connecting the links between what was going in those women's lives and how it was that we were seeing the disproportionate share of preemies in the hospitals. All challenges to the safety net. So the resilience that it takes to do that work maybe is as high as the resilience of the people who rely on the safety net system. When I was the medical director at Mason Square Health Center in Springfield, Massachusetts, I had what some people might have thought was a great opportunity. We were a federally qualified health center look-alike. We were tied to the largest safety net hospital in the city. It did pretty well, usually managing to make a margin of better than 6% every year. And we did pretty well financially because our health center, known for the quality of care that our clinicians provided and that the medical director expected our clinicians to provide, attracted a lot of patients who had commercial insurance, that good insurance as they call it, who could go any place else but chose to come to us because of our quality, our patient-centeredness, our reliability. And they were willing to abide the inefficiencies in our system, which some people thought were tolerable because they only saw us as taking care of the safety net population for whom care was the better than nothing care. So the opportunity from a business standpoint was to say, wow, the highest percentage of uninsured patients coupled with the highest percentage of commercially insured patients still gives us revenue opportunities that if we could keep the revenue, we could invest it back in our system to improve care for everyone. But it was more preferable to our senior leaders to have the commercially insured patients go to private practices. And when some of our counterpart health centers couldn't generate as much revenue, the revenue that we generated, rather going into compensation for the docs that worked with me, went to help compensate docs that worked in other systems. So not really balancing rationally in a way that generates a better system of care for us, but sort of spreading the pain across the safety net while taking away some of what the benefit could have been. Am I making sense? Are you following me? And so there are elements of that that I think we see play out even more now, and we can go on. I mentioned state and federal government, but I don't need to talk like a bureaucrat this morning. So there are lots of challenges to the safety net, and we know them. Demand exceeds supply in circumstances where the resources are limited. There's an imbalance between the proportion of providers who work in a safety net system and the proportion of the population that is part of the safety net. So it's said that maybe 20 to 30% of healthcare providers are actually doing the service or delivery of care for almost 80% of the people who in the US who rely on a safety net. Most people get to choose where they work, and most people choose not to work in safety net populations. Lots of different reasons, including low reimbursement, lots of uncompensated care and costly care. And the situation for safety net hospitals that has contributed to their failing and closure is that much of the costly care, emergency department, ICU, I talked about patients coming in hyperthermic, newborn intensive care unit kind of care, trauma care and ED, mental health, they're costly. They're costly and they're undercompensated or uncompensated, further straining the safety net hospitals. And as a primary care doctor with a real public health heart, I'm always going to say it's even harder for people to avoid needing those higher level cares when there's inadequate access to primary and preventive care, which we know is a national problem and certainly a problem for our safety net. Made worse by our eroding public health infrastructure and strained by the expectation that those who deliver the health care can also do the social work and address all of the social needs. And the heart of the clinicians who want to do it isn't matched by the expertise because we're not trained to do that or the skill set. Parts don't function as a whole. And then something I'm going to talk about a little bit more is an acknowledgement, even at the federal level, that at the highest level of the federal government, there hasn't always been a focus on equity. There hasn't been a true focus on measuring disparities and instituting systems to narrow them. So we can go on. A few years ago, I got into a conversation with some people about, well, who are the safety net hospitals in Travis County? So this, and it was interesting because, I like to be right and I try to acknowledge when I'm wrong, but I didn't really know the answer, so I just went and looked at the state website to see who they listed after a number of people told me that there was only one safety net hospital in the county. And so this is what I came up with just looking at a Texas Department of Health Services website. Are there more safety net hospitals in Travis County than I could find? Monica, what are the other safety net hospitals that the state designates? I see you nodding your head, that's why I called you out. Okay, it was on one list and then it fell off, that's why I didn't include it. Okay, SMCA. Anybody else? Did I leave any others out? Is it possible that some people think there's only one? Oh, audience response, thank you. Do you need to hear that louder also? Yes, okay. Okay, so we can go on. So, I said there were pictures. So, okay, here's the interactive part. I was trying to find some pictures that I thought could characterize our safety net, for however we define it. So would anybody like to put some words to this picture? Say it again? Current Central Health. Anything else you want to say? Or does anybody want to add to that? Thank you. A lot of holes? Okay.
So I see unsturdy and unraveling.
Unsturdy, not sturdy, unraveling. Anybody else? A lot of potential partners. Okay. Anybody else? Many gaps, twists, and turns. Overburdened. Too small. Okay, Mr. Dockery, I see your eyes looking. What were you thinking?
Strung together.
Strung together. Fragmented. Diverse. Something you want to say, Yvonne? You work in communications. Go on. Thank you. Yeah, so don't ask me what I was thinking when I chose these pictures, except for that fishing net for what Central Health is trying to do seems awfully small. To think that any one entity could do it all by itself. And I tried to put some optimism to the strung together one in a way, because at least it was there and it was strung together, but it also, once again, represents a patchwork. So we have opportunity. We have opportunity. And we can go on to the next slide. So, components of a better safety net system. Taking population health approaches to caring for people. And when I refer to population health approaches, I'm talking what I call big P, which is the big public health upstream approaches and social determinants approaches, and what I call the little p, though also very significant, population health approaches that happen inside healthcare delivery systems to really do the assessment of the bigger and smaller population groups being cared for by different demographics or community locations, and putting quality, performance-driven systems in place to manage their care, measure the processes and quality of their care to get to better outcomes. That relies on having effective preventive and primary care. I call health homes. People have talked about patient-centered medical homes, but the notion of health homes also invites in more of the opportunities of embedding that patchwork or a better coordinated social safety net system as part of the healthcare safety net system, and including behavioral health services, all in a way that delivers care and services with a life course perspective. Because I always say it takes being a healthy kid, or it helps to be a healthy adult if you've also had a healthy childhood, and to deliver care that's culturally appropriate. And that a system doesn't reward itself for its good intentions, but by being able to really assess what it's doing through its data that guides the way it's planning, because we can plan with good intentions, but without the right data, what we plan to do might not be the most targeted and most important to prioritize work. And prioritization is key, because it gets back to you can serve some of the people some of the time, and you can please some of the people some of the time. Because under-resourced safety nets, and they all are, always turn out looking like they're creating winners and losers in the context of making the best data-informed decisions. And being able to maximize the use of technology and with accessible technologies, both for service providers and for patients, is important. Because if your systems talk to themselves, but patients can't communicate with them for one reason or another, they're not really serving either. Coordination, I'm not going to say anything about. Balanced obligations and financial burdens across the system. When I talked about being the medical director of a neighborhood health center, people who could have seen patients who were underinsured more readily would say to them, because our health center had a health clinic, go there. So in terms of the weight of who took care of more uncompensated patients, there was not balance. It's not just a matter of whether or not systems choose to share the wealth, and they don't, but they also don't share the burden of burdened populations in the ways that they need to. And all of that is better enabled when equity is foundational to the work. Not just equity for the people we serve, which I would say is number one, but equity in the ways in which we choose to collaborate in the context of limited resources. So we can go on to the next, my busiest slide, but it's not my slide. I took this from a presentation done by experts working with the U.S. Agencies for Healthcare Research and Quality. So if it's not clear already, safety net system redesign is complex. And so this schematic, and I imagine you all can have these slides and see them, gets to lots of what it takes to create a better system. And I'm going to start at the bottom, because I always like to think that you do things on a foundation. And at the bottom here, yes, are we okay?
You're working.
Oh, I'm sorry, I didn't say.
Oh, yeah, no, go ahead.
Thank you. You see, I really do read the room. So, organizational infrastructure, improvement of structures and capabilities, all with a performance improvement mindset. A physician-oriented alignment. You have to take care of your clinicians, your providers. They need to be part of it. appropriate fiscal controls, having the right information technology systems for data analysis, monitoring, and reporting. So you see embedded in this are things like accountability, transparency, people want to know, we need to share, that we are being good stewards of resources. Organizational vision, culture, and goal alignment are too often underrated, but I'm going to say none of this can happen without it. Vision, culture, and goal alignment. Senior leadership support and direction. Commitment to a shared mission. Think about that patchwork. Redesign aligned and integrated with strategic priorities and goals. I did work in state and federal government. It's really, really challenging when you have political support for people who want you to do better, but then they want you to do better by implementing their pet project instead of something that is strategic and aligned and guided by priorities. I said that on behalf of anybody who can't say it, but has lived that in the past. I don't work in government anymore. Well, actually, I guess I do, but Mr. Giesland. And then an active commitment to and participation of staff. I've been there with you guys in Central Health. I know how that's been. And even though it's not here, this community conversation reflects that none of this has happened without bringing community along at the same time. And so it is a really busy slide, but there's a lot in here that's so important. Maybe everybody can take this home and say, how are they doing on care delivery, access, quality, safety, and reliability? Payer mix. I talked about payer mix when I talked about my own health center. Being appropriately reimbursed. Efficiency, cutting waste out of systems. Not just doing things because they get reimbursed at a high rate, even if they're not necessary. And here at the top, and this is where like the pressures on the head with lots of hats, or at least one hat come, pressures from the external environment are all part of system redesign as well, making it complex. Accountability to multiple organizations, accountability to federal funding and regulations, state and local funding policies, local market competition. Maybe I could add in here, what do you do when there is not much in the local market that wants to compete with you and wants you to do it all too, yourself? That's challenging. And pay and care delivery experiments. That also gets complicated because, as we know, at the federal level and at the state level, there have been lots of experiments. It's complicated. So we can go on to the next slide. And within all of it, and where I, sort of settle back in when people say, oh, how are you doing with the diversity work today? I say, but I do health equity, I do quality, I care about diversity, but all of this that we're talking about around giving people access to quality care also means that we're talking about establishing a system that we know is safe, timely, efficient, effective, person-centered, and equitable. The fundamental tenets of quality that were defined by the Institute of Medicine over a decade ago, updated with the recognition that equity cuts across and so does value. But value sounds good, but we have to be really careful that when we think we're measuring value, we're actually looking at safety net systems. And I'll say a little bit more about that in a moment. But the care also needs to, and services need to be transparent, trustworthy, value promoting accountable, accessible, and culturally and linguistically appropriate. That all needs to be a part of it. I listened to a talk, and I can send a link in case you all want to listen to it as well. But it was a number of national experts who work in safety net systems, joined by Dr. Dora Hughes, who worked on the ACA during the Obama administration, and now is back at the Center for Medicare and Medicaid Innovation. And she was talking about how CMS is now really trying to, my words, up its game around safety net care and health equity, with the recognition that, as I wrote on a previous slide, at the federal level, equity hasn't always gotten the focus it needs. Disparities have gotten the focus, reporting what the disparities are. And if you look at reports such as the annual National Minority Health Disparities Report, documenting that for more than 2 decades, a number of disparities in racial and ethnic disparities in healthcare outcomes have persisted, not narrowing at all. So really saying, okay, if we're achieving equity, that we really need to be narrowing and eliminating those disparities calls for something different. And while I'm not trying to shift this conversation from health safety net to primary care, I'm going to go back to having a system that has to have preventive and primary care as a base, a quality system for accessible preventive and primary care, even if a safety net provider knows that in the overall scheme of everything that has to be prioritized, there might be some other efforts that need even more attention in terms of resources and person power. So this is taken from a blog that was just written last month, outlining what the new federal strategy for high-quality primary care includes, which includes changing to some financing, getting away from fee-for-service, and looking to support team-based care, coordination with specialty providers, and community-based supports. That it includes making sure that when they have new models, they include more safety net providers. Because when you say you've transformed something, but you haven't stopped to look and see how it's working in a safety net system, how can you say it's transformed to improve outcomes for the safety net? And looking at new value-based payment models through aligning multiple payers, including Medicaid. And I especially appreciate, having worked in the federal government, seeing something like this come from CMS, understanding, since I worked in the federal government, that net of not so coordinated patchwork could also be seen as what a lot of federal agencies look like. So for CMS to want this to happen for high quality primary care, it means that they have to work really, really closely with HRSA, the Health Resources and Services Administration, that funds so many federally qualified health centers. Because it's also not enough to say, and I can say this with Regina Rogoff sitting over there because I have so much respect for Peoples, and she knows I'm not talking about her. It's not enough just to say you have an FQHC. You need to show that you're doing this stuff. Aren't you glad I wasn't your medical director? I can go on to the next slide. And in that strategy then, CMMI wants to give primary care clinicians more flexibility to deliver the care they want to deliver. And that's huge. Because in my state bureaucrat days, I would invite directors of health centers to come talk to me about quality, but they didn't bring their doctors. Because their doctors were back, and this is, a generalization, I know, trying to make sure they saw the volume of patients they needed to see. And when I would talk to the executive directors about quality, they would say to me, but we don't know about quality. So I said, next time you gotta bring your doctors too. But it's not just bring your doctors, let them drive and work with you to drive having the system that can deliver the equitable quality of care. So, I'm gonna move on to the next slide because I know I'm gonna be out of time shortly and say, I've talked about safety net providers and I've talked about FQHCs, but there's this other safety net realm where people also go to free clinics and charity clinics that are also a little bit different. That sometimes, I think in every medical school I've worked with, there have been opportunities for students to go and work at a free clinic. Well, it's time to be able to say standards for care and quality in that safety net population have to exist there too. So on the next slide, another busy slide that I won't read, is a schematic of a roadmap for health equity created by some people in Chicago and the National Association of Free and Charitable Clinics, which is basically saying it's time to make sure that we define and work towards having high quality in those systems as well. It's not just about doing what's better than nothing. I'm almost at the end with the reminder, I'm not trying to tell you this is a good show, but with the reminder that if you have been just living under a rock or in a bubble and you don't get how complicated it is, and if it's not just so simple to have people roll up to where Dr. Max, what's his last name? Goodwin, okay, thank you, on New Amsterdam works, as the so-called renegade, every safety net hospital needs a medical director like him, doctor. You need to strengthen the health social work. And one of the things this show really does is point out how people show up still relying on systems in the social safety net where jobs, livable wages, and an adequate public health infrastructure, et cetera, are really important. But what caught me about the picture was this little caption at the bottom, break the rules, heal the system. Who likes that? Well, I have been accused of being an advocate, an activist, and an agitator, and all I'm trying to do is give a talk. But some people like break the rules and heal the system. But in my way of speaking, I suggest that we can make the rules and build the system. What do you think? And this, I don't know, this net almost looks like it has a parachute on top of it too. I don't know. But it just seems, it looks better to me. And I think that's where we're trying to go. But it does, it's not just even breaking rules, because one of the things that happens in this ill-defined safety net system is people make their own rules. And they decide when they want to break the rules anyway, and those are the things that help them not uphold equity and quality. And we don't have a system, so we have opportunity. So these are my last two slides. I, this spring, for the first time, went to a Blue Jeans bash, Habitat for Humanity, and it was so inspiring. So when I thought about what we're trying to do and the notion of health homes, it just brought Habitat for Humanity to mind. Because I thought about all the people I saw and all the work that goes into building a house and a home on behalf of someone else. From the planning all the way to breaking ground, to the building the foundation, holding up the walls, putting in all the framework, closing it in, and finishing it off. The planning, the building, the sustaining, the assessing, and the adaptation that has to come. And that's sort of what we need for a healthcare safety net system as well. And if we think that we're doing that for anyone, and remember that there might be people in this room who are part of that safety net population, and if not, go back to where you work, and you might know it, but they are. In the same way that everyone deserves a decent place to live, everyone deserves the opportunity to achieve their best health. And that's what health safety net systems are aspiring to do. And it's been a privilege to be a part of the planning up until now. And I look forward to hearing the panel that follows. And I think if anybody wants to ask a question or make a comment, then Ted will allow that. Thank you.
Thank you so much, Dr. Mullen. You map out our challenges so eloquently, but like a master chef. It's like the right dose of reality and hope and inspiration. So we are really grateful to be able to work alongside you on this journey. Does anybody have any questions for Dr. Mullen? We are going to take a break and have a panel discussion, but before Dr. Mullen leaves the stage, I would like to open up the microphone. Sure.
Thank you. Words of hope in the midst of the chaos we live in, talking about the lives and the health of people. Thank you, and the way we go about doing it. There is a plan that's been made. 2012 in the city of Austin. It was born out of the need to overcome the plan that was made in 1928 that separated our community based upon our heritage. If you're all familiar with that, the 1928 City of Austin plan. The 2012 Imagine Austin plan brought to light planning and doing everything you've presented this morning. We haven't followed it. We haven't even known it exists, but we have a need for it. And I'm grateful that you're casting light on the wisdom and insight on how to go about planning together to serve the needs and the lives of each person, using the skill and knowledge of those who have spent their lives invested in learning how to help us physically, emotionally, mentally. I'm grateful for your presentation, and I want you to know, and I want everybody to know, there exists a plan, the Imagine Austin plan. If we just ask for it to be implemented, it would bring to light most everything you've shared today. Thank you.
Thank you.
Thank you, Steve. Does anyone else have any questions or comments? Or I know this room is full of comments and thoughts, but anybody have any questions? This is one of our Central Health Board managers, Cynthia Valadez. I'm doing my best, Phil Donahue, or if that aged myself, Mike. Oprah. I'd rather be Oprah.
Thank you very much, Dr. Mullen, for your great speech and for providing a foundation for the people here today to understand what is trying to be achieved at Central Health and with its partners, including the city and the county and the enterprise system, Sendero and Community Care. But what is important to understand, and you have very eloquently touched on that, is the need for the decision makers themselves to have those lived experiences of those living in poverty, of those suffering, to overcome barriers. And if they don't have it, and we continue to support them and fund them, knowing full well that they are not representative of our demographic, when do we do that? How do we do that? And yes, we can continue to have these meetings, and we can continue to educate our population that are still living in institutionally racist systems. But we do have to achieve that in order to eventually integrate an equitable system. So I just want everybody to think about, if you're interested in being at the top, well, climb to that dadgum top and be involved as a decision maker, because we all know what happens if you're not at the table. You're the dinner. So we have been the dinner for too long. Now we want to be at the decision-making table, making those decisions that are impacting our lives. And for the poverty population, the targeted population, those living under 200% FPL, that we are needing to focus on right now. Thank you.
Thank you. And thank you for coming so often when I've done things at work, at the other work. Thanks.
Thank you. I'd also like to acknowledge another one of our board members, Amit Metwani, at the back of the room. Amit, thank you for being here.
I guess the only thing that I wish that when you do your speech next time, that you also include is discussing the lack of support from the Texas legislature, and discuss with everybody the importance of voting and the importance of getting all of their friends and all of their relatives all over the state to vote, because that also could benefit the healthcare system.
Thank you. I totally agree. And I actually, should I call you Manager Valadez? Commissioner Valadez? Well, I didn't want to do that. But when Cynthia was talking, I started to say, and people really need to vote. And I won't tell you who to vote for, but please vote for your best interests. And in the way in which we think about this, you get to prioritize what your best interests are. I was hoping that I made a case for what they might be.
And I have no doubt, Dr. Mullen, you could preach about voting. So that could be a whole other keynote speech.
Yeah.
So thank you so much.
Okay.
I want to remind you, we'll take a couple more questions. This is being broadcast live on Facebook. It's also going to be recorded, and it'll be on our Central Health Facebook channel or platform, so you can go back and listen. We are going to take questions from our audience live during the panel conversation. If we don't get to the questions, we do pledge to answer those and post those on our Facebook page. So I saw another hand back here. Please.
Thank you, Doctor, for your presentation. I've been lucky enough to work all over the world, from Europe all the way to the Middle East in medical care. And I know there's an evil word here in the US, but what you said is called social medicine, right? It's not communism. I'll be happy to sit down with anyone and see the difference. And Europeans weren't, not perfect. We can bash them too. We can get together and do that. But what I just wanted to say is that, we need to be a little bit more open as a country. When you go to Europe, for example, in Spain, it's healthcare for everyone, universal. And what surprised me is the US is not on that list. We are not. To other countries, Mexico is. If you're a Spanish citizen and you go to Mexico, you get free medical care. And I think it's just like what you said, we need more people like you that are looking out for the patients, not just the prestige of it and where I sit in society. So thank you very much. I enjoyed your presentation.
Thanks.
Dr. Mullen, exceptional. Thank you. And my question is, based on your experiences across this great country and bringing thought leadership to so many different entities, how can Austin Travis County be a leader in health equity and for the safety net populations? If you could just say that in one or two sentences as a challenge and encouragement.
Thank you for your question. I think a couple of the comments have gotten to it. It's really easy to be overwhelmed and think things can't change because who's in the White House or who's in Congress. Many of those people got there because they first had some role in local government. Not all, but many did. Don't think things are impossible because of what's happening nationally. Don't believe you can't make change locally. And then what I would say is we have enough data about the realities of the lives of most people who live here or who have been here since before 1928 even, that it's okay for us to look at that and not just be proud that we're in Austin and want to tell ourselves, at least we're in Austin. Do I need to say any more? Okay.
Doctor, I was just wondering, from your experience, when you've been in New York and now with your Dell,
equity, making sure people have access to the care that they need. Equity, making sure people have access. Equity, making sure people have access to the care that they need to have health be as good as possible, has to start with assuring that people can actually get the care. But that's not enough. And so while Central Health has been the foundation for our county for assuring that people have access, now, along with that, we have to be sure that people are actually achieving their best health.
Dr. Mullen serves as our Director of Health Equity and Quality. More specifically, she's going to sit next to us as we develop our healthcare infrastructure in order to make sure that individuals, regardless of demographic or background, all have the opportunity to achieve an endpoint of quality of life and of wellness. The work that we will be doing as a team is looking not only at the health status of individuals, but their social determinants of health and other factors that influence their ultimate health. And so it may be that we have to focus on transportation, on the fact that many of our patients can't afford their prescriptions, and so we need to look into what that means and address that. Many of our patients live within food deserts, and so giving somebody a diet whereby they have to eat more healthy may not be possible unless we create coupons to various access points for food so that they can succeed in their health. Dr. Mullen is going to help us ensure that as we set up our clinical infrastructures, that we are considering these questions and others to better ensure that our patients are successful.
I'm Dr. Jewel Mullen. I've been at Dell Medical School for almost 4 years, and I'm really excited and grateful to now be in the role of Director of Health Equity and Quality for Central Health. Even before I started at Dell Medical School, I knew that working with Central Health was essential to the work that I wanted to do to assure that we created every opportunity for everyone, especially the most vulnerable and medically underserved individuals in Texas, Central Texas, Travis County, have their best opportunity to be healthy. In my view, that's always been Central Health's mission anyway. As a starting point for my work with Central Health, I've been grateful to be on the Medical Executive Board because we are able to look at the really good work that's been going on for years, assuring access to people who need care, primary care, and specialty care. A health equity and quality approach gives us even more of a chance to use data, information about where people live, people who need the most care, and how we make sure that the services that they need are available to them and effective to meet their healthcare needs.
I want to thank everybody for coming out today. Name is Mike Giesland from Central Health, and we've got a host of team members here and community leaders. When we get the opportunity to celebrate these different milestones, we're certainly going to take it because it's proof that what is long overdue is finally being put on the ground and being brought here. And while we're going to be signing a beam today, and I know we're going to hear more about the significance of this here in just a second, this is a commitment to the community. And is it about a building? Yes, but it's also about what happens within the four walls of those buildings and the programs that we bring about and the health disparities that we can overcome and the equity that we can achieve. So this means so much more than just a building on a piece of land. This is big. And so we want to thank everybody for coming out and helping us celebrate and recognize this. Thank you.
This is more like a time capsule. So all of you that had part in building this and improving it and being part of the community, 100 years from now when this building gets remodeled or renovated or taken down, y'all will be here like a time capsule.
we're talking about health equity today, and when we're connecting with patients and we're thinking about what is it that improves the patient experience, that is part of health equity. And when you look at helping people live the healthiest life possible, that also captures everything that happens both within the clinic itself, but also outside the clinic. How is it that we engage with patients to make sure that they know of all the resources that are available to them? How do we connect with patients after they've been discharged from the hospital? How do we make sure that we're meeting patients in a culturally affirming way? All of that together is health equity, and that's what we're here to talk about today.
This program or forum is where we have been learning how MAP works and how it's planned. It's truly very interesting because I've learned about the benefits and the deficiencies. And we have an opportunity here to make our voice heard because the people who do the planning are here and it will help them improve it.
Today I learned about marginalized communities and where they're concentrated as far as living 200% below the poverty line. The resources that I found in there were very, very helpful. The plans for the future are really, really great. All the specialties that are going to be coming in, all the providers that are going to be folded in, definitely positive information for this growing community in the years that are coming.
Welcome back, everybody. Thank you so much for sticking around for the rest of our community conversation. I did want to also mention we have a couple of different tables set up here in the room. To my right, your left, is our Central Health HR team, our recruitment team. So if you have questions about how you can join the organization, please stop by. It is more than a job, and it's a passion. I hope that has come through so far and will continue to come through as we continue our conversation. And then to my left, in the back right, we have a table set up for our Community Health Champions program. We could do a whole community conversation on this group. This is a group, a volunteer group that really, they are the ambassadors for Central Health, and they will tell you how you can apply to get in the program. This year is our 8th year? Or 8th year, and I think we had more than 110, 120, 115 applications this year for the Community Health Champions program. So that's going really well. And then finally, my colleagues on the outreach team, Aida and Blanca, please raise your hands. These are the folks who are out in the community each and every day, connecting people to care and to coverage. So getting people enrolled in our medical access program. If you'd like to learn more about how you can apply for the MAP program, or if you would like to help us spread the word and get people enrolled, please stop by and talk to Aida and Blanca. They are the experts, and they'll be glad to guide you. In 2022, February of 2022, the Central Health Board of Managers adopted a healthcare equity plan. What is that? We're going to talk about that today. We are designing a comprehensive, high-functioning, safety net healthcare system for Travis County, and Dr. Mullen teed up this conversation beautifully just a few minutes ago. As we get started, I want to remind you again that this conversation is being broadcast on Facebook Live. It will be recorded. We will take questions from you in the audience and also from people who are watching virtually. I'd also like to pause and just thank my colleagues who have a moniker, the Dream Team, but the folks that I get to work with every day. I'm blessed and fortunate, and they're the ones who made this happen. So from the venue to the beautiful flowers, where's Katie Nance? She's a health champion. She brings it every day. She is so beautiful. But Yesenia, Yvonne, Mike, Edwin, Isela, Aida, Blanca, and Jennifer, who's capturing all sorts of social media content, and Tara, thank you all for making this happen. And thank you to ACC, the ACC catering team, the folks working the AV, they've been amazing. So we are super grateful for everything that they've done. So let's get started. I want to introduce our panel. First, Dr. Melinda Zabramba. She is Central Health's relatively new Associate Chief Medical Officer and part of our Medical Executive Board. Dr. Zabrambra holds a Master of Business Administration from Indiana University's Kelley School of Business. She also completed her Doctor of Medicine and Bachelor's in Biology and Chemistry from Ohio State University, so you're a Big Ten kind of person, was. She's board certified in family medicine, passionate about giving back to the community, that's already evident. She actively participates in a lot of different organizations, American Heart Association, Girl Scouts, I'm gonna flip my page because there's a lot of them, Student National Medical Association. Welcome and thank you for being here, we're really grateful. Cynthia Gallegos is Central Health's Vice President of Operations. 12 years of healthcare operations experience here in the Travis County area. She oversees our service delivery operations team. Cynthia's a little busy because you may have heard there's a clinic opening just down the street, our Rosewood Zaragoza Specialty Clinic, and Cynthia is intimately involved in leading the opening of that clinic. She's from the Rio Grande Valley, but graduated from Texas State in healthcare administration and then got her master's degree at St. Edward's. So thank you, Cynthia. And then my colleague, Monica Crowley. Monica is our Chief Strategy Officer and Legal Counsel. She has a long bio, and I'll mess it up if I go through all the details, but she joined Central Health in 2014. Her professional experience is more than 25 years as an advocate and attorney for public entities and nonprofit organizations. Before joining Central Health, Monica was Vice President of Strategic Communications for Lone Star Circle of Care, one of our partners here in this Central Texas community. Before that, she was a white-collar, I love this part, white-collar enforcement attorney for the Texas State Securities Board and the U.S. Justice Department Antitrust Division. She also was an assistant attorney general with Medicaid Fraud Control Unit here in Texas. So, Monica, thank you for being here. That's why Monica asks really good probing questions. And then Dr. Mullen wasn't originally part of the panel, but then we thought, you can't leave, you've got to stay here and be part of the conversation. So we wouldn't let her go. So I owe her a latte or something here in the future. So, let's get started. Monica, I think we have a slide here at the very beginning. As you know, most of us here understand that the people that we serve here at Central Health, often they are uninsured, they are low income, they face many barriers to accessing care in our community. And this slide might overwhelm you in the beginning, but Monica, what is a comprehensive safety net healthcare system, and how does that address the challenges that the people in our community are facing?
Well, and thank you, Ted, and thank you, Dr. Mullen, for joining us. Dr. Mullen has joined us in this work since 2020, and part of Central Health initiating this work after seeing the disparities that came out of the pandemic in 2020, particularly in the communities that are served by Central Health. We decided that we really had to, although there's not a definition that is a one-size-fits-all of a comprehensive high-functioning system, we decided that we had to take a systematic look at the healthcare system, that we had to identify gaps in the system and what a system that is providing healthcare services that are readily accessible when people need them, that are equity focused and culturally appropriate, that are the high functioning part is that it is both comprehensive, culturally appropriate, and that it is continuous and sustainable over time. And this view that was developed not just by Central Health is obviously something that no one organization can do on its own, no one type of organization can do on its own, and it is just a starting place for us to look at, so it's not going to remain stagnant over time.
and we don't have time to go through this entire slide, but this is the end goal, correct? This is what a high-functioning, comprehensive safety net healthcare system would look like?
So this is the group of partners, stakeholders, healthcare providers, folks that we collaborate and work with, set out as what a comprehensive, high-functioning safety net system for Travis County could be. If you notice, it includes and it also is a complex diagram. There are dotted lines at mental and behavioral health, because that's not just one kind of element that has to go across all of the elements. And it also includes kind of a central cog, and there are all sorts of different depictions. You could build it like a house, you could build it, like cogs in a wheel. The center part are things that are foundational and cross-cutting. They're either central to the system or
non-negotiable,
they're foundational.
have to have them.
Yeah, yes, absolutely. Enablers, things like care coordination, things like data that's shared across the system, things like what Dr. Mellon said before, a form of payment to make things financially sustainable. And then if you look around the outside, there are areas like primary care, specialty care, hospital care, other preventive care, public health, that also have to work kind of consistently for people to be able to move across the system. And we use this graphic to both depict and help us think about where we might be headed, where we've identified gapped areas where people get stuck today, where we don't, that need to be filled. And then also as we come back, to depict, now that we're moving forward, to depict areas where we are taking action, where we're working with partners, where we're building out infrastructure, and so we can come back to this and depict work that's been done as well.
Yeah, and I mentioned that the board adopted our health care equity plan about a year and a half ago, and the work is already happening, and we're going to talk about that. Dr. Mullen, I'm curious, when you see that slide, every community is unique. We like to think that Austin and Central Texas is the most unique. But does that diagram work for all communities when it comes to building a safety net healthcare system? Is the model the same?
In terms of ingredients, I would say...
And you are the chef. I mentioned earlier.
I would say yes. They get to the health care and the social safety net. They also allow the opportunity for people to see themselves in it, as opposed to thinking it's all what Central Health is primarily responsible for. And the notion of gears can apply to all if they decide they're willing to align, coordinate, and collaborate. The other thing, this is just my opinion, is that somebody has to drive it. And when it comes to being the one who has the most authority, maybe what we don't see there is who's really making sure the big cog is turning. That's what I call I've used this a lot, like the dog wagging the tail. And what our community hasn't had as much of a benefit from yet is really having the dog be able to wag the tail to make it all turn the right way.
Thank you. I want to rewind a little bit, and Cynthia, I'm going to ask you this question, but let's talk about how the healthcare equity plan was developed. And we had a comment on Facebook earlier during Dr. Mullen's keynote, and I won't repeat the comment word for word, but essentially they were making the point of ensuring that our patients the people that we serve, and Manager Valadez mentioned this as well, that they have a seat at the table and a voice in the process. And will you talk a little bit about how this plan was developed and how it was developed in partnership with the community?
Absolutely, Ted. So thank you for that question. I can share that there were two pretty significant initiatives that went into the planning for this strategy. One of them was the voice of the community. The voice of the community was an effort where we really brought input from key stakeholders such as patients, community serving organizations, partnerships that Central Health has, as well as the patients themselves that make up the Central Health population. And we really wanted to hear from them what were the challenges that they were experiencing on the daily in attempting to try and access care. So that, along with really helping identify the drivers of change from the people that are experiencing it, really helped inform kind of how this plan came together. The second initiative that went into the planning of this was the Safety Net Community Health Needs Assessment. So this is really where Central Health attempted to get a pulse check on what was the health status of the community, so that we could really better understand the inequities across the county and really where the critical clinical service areas and the support services were in need, so that we could really help inform the work. So that paired up with what we've referred to as a capabilities and gap analysis that was more of an internal reflection of the organization, really helped inform how this strategy came together.
Thank you. And I should mention that the Healthcare Equity Plan is available on our website, so you can read more and download more. Also, if you have questions about what we call the voice of the community piece, our outreach team is here and we can talk more about that engagement process. It wasn't just a survey, it wasn't simply an interview, it was a very in-depth conversation with members of our community, both our patient population, people who could be part of our patient population, and equally as important, the groups, organizations that are serving the people that we serve, so the people that we were in partnership with. Question, Monica, there have been a lot of studies. People probably sometimes feel like they're studied out, but this is a first. This type of assessment, this type of gap analysis has not been done in Travis County before, correct?
Absolutely. Central Health has participated in and continues to participate with the city and the county in the overall, what's called the CHA and the CHIP, which is a community health assessment, and then the community health improvement plan. And we absolutely continue to be part of those efforts. What was the first about this community health needs assessment is it was the first that was focused specifically on people living with incomes below 200% of the federal poverty level in Travis County. If you were specifically looking at access that's available to health disparities, burden of disease, and barriers to getting care, you're going to find something that is different if you were focused on the population that is served by and could be served by Central Health than if you look at the population of everyone in our community.
Dig a little deeper into the gap analysis, and I think this is the next slide. So these are the areas of unmet needs in our community, both minimal, moderate, and significant. And we would welcome questions, but as we talk through this, I imagine everybody in this room could probably raise their hand and share a personal experience regarding one of these areas. But can we walk through these? Let's start with the significant gaps, and I want to bring Dr. Zabrambre into the conversation as well. But let's start with the significant gaps that currently exist in our healthcare system.
I'll kick us off on that. So there were a couple of areas that were identified as having significant gaps. I think 4 in total. Yes, sorry, I'm blind to that one.
It's a long way away from you.
All right. So the significant gaps were in specialty care, dental care, hospital services, and then post-acute care. But that's not to say that, I think on this slide you can see that there were also moderate gaps that were identified. And we defined that as an area where about 50% of the need was being met. So I'm not sure if you'd like to add to that.
And I do think that that is something I want to make sure that this definition of what a significant gap is, if we are only meeting in these areas up to 50% of the need in the community, and a moderate gap is that we are meeting between 51 and 70% of the need. And one of the things that I think it came, I think, as a little bit of a surprise to us, particularly, is that there are moderate and significant gaps, moderate to significant gaps in every one of these areas, and it's even in areas where where we have made significant investments over time.
And when there's a gap, what does that mean to a person, a real person? What is difficulty getting an appointment, getting a referral? What do we mean specifically?
So when you think about it from the patient perspective, it's access to the care in general. Do I have the specialty available to me? Am I able to go to this appointment and get the care that I need?
Thank you for that. So let's go through these in a little bit more detail, and then we're going to move to the next slide where we'll start to talk about some solutions. But let's walk through again significant when we talk about primary care. So timely services, we mentioned that, getting an appointment. Access to social services, what would be an example of that?
Specifically things like transportation, ability to pay. A lot of our patients also have difficulty with being unhoused as well. So just making sure that we're meeting the needs of the patients that we serve.
And these were some of the barriers that came up during our Voice of the Community conversations. Transportation was a major barrier. Think about ourselves. If you had more than one appointment in a day, how do you get from one appointment to the next? Language was another barrier that came up. And then when we talk about wellness and prevention, patient communication and education, we heard from the community that they want more information about wellness, prevention, how to stay healthy. So all of these things resonated with not only the data, but also with the people that we spoke with. Anything to add on the hospital-based post-acute care? These are minimum gaps, but they are still things that we're addressing, correct?
That's correct. And what I can add there is that we have several initiatives out today this current fiscal year in those areas to really try and help bridge with patients moving from one entity to another, ensuring that they have the appropriate support and the warm handoffs in the various areas. So areas such as the skilled nursing facilities, right, so that they can be receiving them with the right information. And then, once again, if patients are discharging towards their home, making sure that they have all of the tools necessary to have a warm, safe place to be.
And Ted, just one of the things I want to be clear on is if you look at the hospital-based and post-acute areas, those are areas where we do have significant gaps.
Yep.
And if you look at some of the, and I don't want to get ahead of ourselves because I know Cynthia and Dr. Zambrava are going to talk about this in a little bit more detail, but some of the areas that we began working in first, like adding additional access to respite care, are areas both that are significantly gapped in our community that we really don't have necessarily meaningful access, that we both have to work with partners and then work on longer range plans to more greatly expand that access by actually building some additional access.
And I wanted to also, you said something during the initial slide that shows a high-functioning healthcare system about behavioral health, which is listed as a moderate gap, but that's part of everything that we think about and everything that we do.
Yes, absolutely, and that's also some of the initial work that's happening is you know, and you guys are going to talk about this in more detail, but areas that are gapped, like substance use treatment, expanding that through expanded partnerships, and also bringing primary care, behavioral health, expanding access to that, working with our partners, and also continuing to work with integral care to expand care for people with serious mental illness as well.
Let's move to the next slide to talk about the strategies that are guiding this work. And it's important to note that this isn't a 1 year or 2 year or 3 year plan. The plan that we're talking about today is a 7 to 10 year plan, but then we'll go well beyond that. But we talk about the strategic imperatives and what's driving the work.
Hello, okay. I'll take this one, Ted. So access and capacity is an area where we're really looking to increase providers and care teams, both with our partners as well as within Central Health in this next coming fiscal year, as well as in future years. As far as care coordination, I think I mentioned this earlier, but this is really where we're putting a lot of effort and focus with partnerships as well as internally on the care coordination and the transitions into the various settings. As far as member enrollment and engagement, we're really looking to enhance engagement for enrollees and working towards expanding enrollment in the high-need regions. So that's definitely an area of priority for us. And then for the system of care and infrastructure, that one hits home. That is really the joint service delivery planning and timely sharing of healthcare data. You know, I can look at a colleague here in which that is an area that she is constantly working on helping bridge the gaps that we see within the community. So those are the areas that we've definitely identified as imperatives for the organization.
Thank you. I want to pause and see if anybody has any questions or comments before we move on to the next. Yes, sir.
I just want to put some context. My name's Gavino Fernandez Jr. I'm an Austin native, former chief of staff for Commissioner De Leon when the court approved of FQHCs, the clinics going there. And I'm also a customer. My commissioner would always tell the social agencies, they're not your clients, they're your customers, okay? But we're not treated that way. I personally, and right now I'm going through a negative experience in enrollment, in reapplying. I ran out of medication. I'm diabetic and high blood pressure medication, and my card expired. And since June, I have yet to get an appointment. I have yet to be able to get my medication. I did receive a call, and I've returned that call every day. I'm still waiting. So everything you're presenting, I'm coming from a bureaucratic lens, to me seems like a mirage. And I'm not the only one, because being involved in my community, we get a lot of issues like this. A dental appointment, 8 months. A follow-up with God helps us in being able to survive that. But it's interesting that when UT wanted money, it was made available real quick. So a lot of what I have seen, and I opposed the district when it came about because I knew we were going to be in this kind of situation. And it has not gotten any better. So, you know, I hate to bust your bubble, but you're a far cry from the delivery of everything, all the jargon and the presentations that y'all make. Because as of to date, I have yet to get an appointment to reapply for my participation in this system. So food for thought. I commend you for trying and wanting to go there, but the boat is being missed. There are many patients that are being left at the bus stop because we're so concentrated in doing all of this. Thank you.
Thank you, sir.
Ted, can we try and provide a response?
Yeah, I'm sorry, but I know they're there, but that doesn't do me any good.
Can I just add one comment to that? I really do appreciate you sharing that. It's a real experience, and I think this is exactly the voice of the community speaking. And I want to personally acknowledge, like, these are real events that we work to solve on the daily. So thank you for trusting us with that, and know that behind the pretty presentations, there is so much work going on to work towards filling those gaps. And we're getting it wrong, and we're working towards solutions as we kind of come out and provide where we're at today. So thank you for that.
No, absolutely. Thank you so much, Mr. Fernandez. And that does really highlight, I think, the key focus of the work that we're working on right now is identifying major gaps that exist. And these gaps, when we say something is 50% gapped, then you are the person, the human being that should be receiving these services, that because of that major gap is not, it's the picture of the nets that Dr. Mullen showed, and you're right, that this can't just be about a slideshow presentation or about words or a conversation here. We have to put the work behind it, and we have to deliver. So thank you so much.
So I think this comment's relevant. Concerns that were just brought up, because sitting here with my coworker Richard Johnson, who, like myself, my name is Joshua Collier, we're both community health worker instructors and community health workers. Community health workers are a solution to the problems that were just discussed, and yet the capacity is very limited. And so I think I appreciate Central Health's community engagement. It's happening frequently, right? I was told at the registration desk that, having been involved along with Richard and our coworkers in Central Health's Community Health Champions program, that our feedback has been incorporated into a lot of strategic planning. And I think what we see is that the knowledge, and not just in direct care that community health workers can offer in clinical spaces, but as consultants, community health workers there's a missed opportunity there, right? It's important to consult directly with patients, directly to evaluate the quality of care, right? We need to be hearing feedback at the clinic level. But those of us who are bridges between patients and the health systems need to be involved in discussions around how to create process improvement. That's basically at the core of the conversation today. How do we improve what's going on, right? We're crucial to the very first slide here, the hub in the middle, to every piece of that middle cog, right? We're also crucial to every piece of this slide. All of these strategic imperatives community health workers can address. Care coordination, that's what we're doing all day long. We're experts on coordinating between systems, right? Currently, and just to speak to the potential of community health workers, and not just myself, but also my coworkers and folks throughout Central Texas. So I'm a co-developer of the social and health information platform that's shipped through DelMed. So as a community health worker, I help co-develop a health technology platform. How often are we inviting community health workers to be involved in that kind of work? I'm also participating in the working group of Child Chip that was mentioned before. Also on a community advisory committee helping develop Austin Travis County's first food plan. And not just participating, but helping as a facilitator for those meetings. That's not unique to me. My coworker Richard's here. Earlier in the video, that was our coworker Chris Mora. We have a couple other very talented coworkers, Tanya Degtoff and Megan Moak, based at Dell Seton Hospital, at Dell Children's Hospital. And so I just want to encourage this solution that's right in front of us all, and to increase funding, to increase support. And I would love to hear your thoughts on the importance of that, or plans to do that moving forward, related to Central Health's plans. Thank you.
I can help address kind of our stance with community health workers, and then Monica, I don't know if you want to help add to this, but I'm really glad you brought that up, and it is probably jumping ahead because it is something that we really pride ourselves in some of the future work that's coming. But there's been a lot of effort in really centralizing our community health workers that we currently have, as well as looking at what is the opportunity for us to continue growing individuals within the community in that space. And so one of the initiatives that we have lined up for next year is really designated around bringing in students and or community members in the community health worker space and really trying to see how we can put them within the organization, within the community, so that they can be helping us serve exactly what you said, the connections here with the strategic imperatives. So really appreciate you bringing that up. I think we'll speak to it a little bit more, but I don't know if you want to add anything related to the CHOT.
Well, and not necessarily related to the CHOT, but I think just to your comments about participating in planning efforts, particularly as we're building out programs not specifically just about transitions of care, not just about eligibility and enrollment, not just about services that will be provided to expansion of services for people who are unhoused populations, but also services for people as they are moved into permanent supportive housing, and particularly the discussion around the diversion center. There are a number of areas where I think the perspective of community health workers that are not just on M3 teams, not just in hospitals, not just in settings where people are receiving care, are important to the design of how we're going to actually, turn this work into, real services for people. So thank you.
Thank you. And this is a long-range plan, and I think it's a good reminder, though, that as we're working on long-range goals, we're also making things happen immediately, because if we don't, there are people who are waiting and or suffering and needing. So I would like to move to the next slide and talk about some of the work that is already underway that is in support of the healthcare equity plan. There are several different areas, and these will also guide and shape our upcoming budget, and we'll talk about that a little bit later in this conversation. But Dr. Zabramba, do you want to talk a little bit about some of the areas and initiatives that are already underway?
Yes, thank you for that. I do want to address the previous comments as well. The graphic that we showed at the beginning, it's complicated on paper. So just imagine all of the people and the processes that go into that. It's going to take time to get to where we need to be. And, with the previous slides, we have to address where the gaps are. And this is a great segue to talk about the fact that there are patients in this community who need dialysis to keep them alive, and they were told they could get it compassionately if they come to the ER when they're basically knocking on death's door. Central Health developed a program so that these patients don't have to do that. They gave them a place where they can go and get the care that they need, and even beyond that, make sure that this isn't a temporary solution. They move them so that they can get this permanently, so that they're getting the care that they need. The other place to look at is podiatry services. We primarily take care of our diabetic patients. I mean, think about it from our perspective. I'm blessed to get up and walk around and do the things that I need to do, but how can I do my job and care for my family if I have a wound that's not healing, or I'm gonna lose my leg because I got inadequate care? So we have podiatry services. I think there's been over 60 surgeries that have already been done, and we do have a specialty care clinic where we're gonna expand those services as well. I think another key piece that we talked about is hospital care and post-acute care, which is exactly what our transitions of care and medical respite take care of. So when you think about medical respite, when you're in the hospital, you have an acute need, but once that acute need is done, it's time to go home. Well, what happens if you don't have a home? How do you recover from a major surgery on the streets? How do you undergo chemotherapy and cancer care if you don't have a home and a place to get your nutrition? So that's exactly what our medical respite takes care of. It's those people who aren't quite sick enough to be in the hospital, but also don't quite meet the criteria to be in a skilled nursing facility. We bridge that gap so that they can heal and not have to worry about the basic needs like a home and food. Our Transitions of Care program is another excellent program that we are expanding. Central Health specifically is going to go into those skilled nursing facilities to make sure that the patients are getting the care that they need as they're bridging from the hospital, and that we're not just leaving them there. We're making sure that they have the resources needed so that they can be successful even when they're discharged from there. And the final point would be the substance use disorder treatment. And I think it was, I have to look at my notes, in May of 2022, we declared an opiate overdose crisis. And Central Health responded to that. We had already been doing medication-assisted treatment since 2019, but we expanded those services as early as July, and since then we've been doing more with methadone treatment so that we can address that crisis and meet people where they are. So ultimately, the one thing that I'm new to Central Health, I'm new to Austin, but the one thing that drew me here is that it's more than just on paper. They're living their mission, which is meeting the needs of the community and improving the health.
Thank you. I wanted to just mention that if it's not clear already, we don't do any of this alone. So regarding, for example, substance use disorder treatment and the opioid crisis, Central Health worked with Travis County, Integral Care, Austin Public Health to develop a public awareness and education campaign, One Dose and It's Over. We have a long ways to go, but I just wanted to emphasize the fact that we don't do this alone. We do this in partnership and collaboration. That's an example of a community-wide challenge that requires a community-wide response. Does anybody have any questions about this slide before we move on and talk about action? We can't just talk, we have to actually move. So, yes? Let me give you a microphone.
Good morning. It's more of a comment, not a question. My comment is that when Doctor said you have to vote your interests, these are the interests that we're talking about. When we have 10 respite beds and we have 30 patients in the hospital, where do we put those people? What do I get a phone call at 12 o'clock saying that we're discharging a person with a heart pack and he's going to street? Do you have a tent? I shouldn't have to have a tent. The person needs a bed. I asked, where is he going to charge his battery pack? She said, Denny's, Burger King, McDonald's. Wouldn't be able to stay there, right? So the question is that the interest is taking care of our neighbors, taking care of our citizens, taking care of our community members, taking care of somebody's mother, father, daughter, sister, however you want to view it. That's where we need to be. The mission needs to be is take care of one another. Kindness works well. Kindness is needed. That gentleman showed up and put out his heart of what his needs were. Closed mouths don't get fed. And he only asked, look, I need this just to survive. And so that's somebody's grandfather right there. So just when you decide on what you want to do, don't put what your interest is in the ballot box. Put what you want to see for kindness for all.
Well said. Well said. I see a hand.
I was a coordinator, manager, and intensive as well. And one thing, going back to community, it's that we have individuals that are therapists, music therapists, art therapy, and they're getting paid less than people that work at McDonald's, right? I'm sorry, I work for a nonprofit. Believe me, if I wanted to be rich, I would not be here. I'm multilingual, I've worked all over the world. Believe me, I could be making much more than what I'm making right now. But it's just so frustrating when I go to my clients And I say, oh, we have music therapy, we have art therapy, equine therapy, rec therapy. And then I go back to my place of work and they go, well, there's a waiting list because we only have 3 music therapists. We only have 3 art therapists. And I work with trauma patients. So for me, it's just like we need to restructure it. And one thing is, you know, like I said, I lived all over the world. We have to get over the majority, I won't say everyone, but the majority of the American public, me, myself, and I. We need more love. We need to understand that we need to change that. Because as long as we keep on doing that, me, myself, and I, as a society, we're not gonna go forward. So I just wanted to say that you know, workers that are here, the frontline workers such as myself, we need more support because we see it every single day. We go home talking about, you know, in our heads about our suicidal patients, you know, our bipolar patients, and they're not getting what they need. So for me, it's just like, I hope people are looking at that, such as yourselves that are, you know, working for us, and just take us into consideration, because we are humans too.
And thank you for what you do. Monica, let's move on to the next slide and talk about action, because I think this is what's next, what's happening, and what's next, how we go from planning to action. Do you want to walk us through the next? There are 38 initiatives, 150 projects, and perhaps just quickly how we got here and how we narrowed this down and brought this into focus.
Yes, and this is a continuation of the work from the Healthcare Equity Strategic Plan, is really figuring out how do we come up with a longer term approach for starting to actually fill the gaps and fill the needs that have been identified. You know, as Dr. Mullen pointed out at the beginning, this is work that will take many years, and is work that when you see so many significant needs, it's work that you can't take on at once. And so I think the approach that we took was not to sit on our hands. We started, you know, in 2022, the board adopted the Healthcare Equity Strategic Plan, and we began the work to contract for additional respite beds that were available that we could find. We are still continuing to try to, you know, expand that as much as we can, as we also start working on longer-term solutions like the facility at Cameron Road that will have 50 additional respite beds, along with another adjacent facility with comprehensive kind of wraparound specialty care, substance use, detox services. Some of these things that both we can immediately start working on just because the high level of need, continuing to work on building out navigation center services and these eligibility and enrollment projects. Some of the areas that you know, you see today that are these most pressing community needs, as we continue the planning work to come up with a longer range comprehensive plan, which we have never done before, to have as a North Star that we can work with partners on. And so we took this approach. We looked at the moderate and significant need areas that you remember from the previous slide in primary care, in specialty care, behavioral health, dental, and in hospital and post-acute care. And based upon feedback we've gotten from the voice of the community, based upon data and information that we had about burden of disease, geographic areas, based upon capacity that we have an organization, as an organization and capacity of partners that we could collaborate with, and based on the size of the gap, we identified 150 projects that could be an approach to address those needs and fill those gaps. And then we continued to prioritize those projects based on ability, effort, need, and came up with what are some quick wins that we have the capacity to achieve more readily. What are things that are so foundational and so pressing that will take a number of years, but that we have to start now in order to achieve this goal of meeting the need down the road? What are some things that we need to revisit a couple of years down the road? And then what are some things we need to really focus on collaborating with partners on trying to achieve, because they're interdependent projects. And we organized the 150 initiatives into 150 projects into 38 initiative areas, including in the area of primary care, healthcare for people who are unhoused, more same-day care, extended hours, and virtual options, including expanded access to primary care, including looking at Community Care's HIV and AIDS program, and expanding access to pharmacy across the system. In specialty care and behavioral and dental, really looking at expanded access to specialty care, looking at substance use disorder and addiction medicine services, increased access to mental health services, and expanded access to dental care.
And Monica, I was just going to say, like, when I look at the primary care priorities, 2 clinics are coming online in Eastern Travis County this year. So in Hornsey Bend, Del Valley will offer pharmacy services. Both clinics will offer primary care, virtual specialty care as well. So those are just tangible examples of things that are happening now that you're going to see opening in the next couple of months.
And Ted, you'd mentioned before, and I think Cynthia and Dr. Zambramba also mentioned the Rosewood Zaragoza Specialty Care Clinic.
Like
that
2 blocks
is,
from here?
You know, that, yeah, you can't
walk.
get here almost without driving
degrees.
past it. And then on the hospital post-acute side, increased access to hospital care, expanded access to surgical and procedural care, and also this robust post-acute care, including both this build out and purchase of additional respite care, and then making sure that we have connectivity once people are in those settings. So making sure that we have service providers in those skilled nursing settings. We have community health workers and nurses in the other post-acute and respite settings, so that we can ensure that people that we're serving continue to be connected to this larger system.
We're going to take a quick question.
What seems to be really sad to me is that we as a society, it's just a really big deal to go go make a computer, and yet there are so few. There aren't enough nurses. There aren't enough technicians, and I don't know if you think it's a matter of pay scale, or do you think can you think of other ways to encourage people to go in those fields? Because I know I recently saw Dr. What's-His-Face, who the psychiatric thing, who said that ASH can't fill even the beds they have because there aren't enough nurses. And you have all these people on waiting lists. And do you have any thoughts? Does anybody have any thoughts about how to encourage more people to go in that field?
Well,
Thanks, Lorian.
yeah, no, thank you so much, Lorian, for that question. I'm gonna pass it to Dr. Mullen in 1 second and then over to Cynthia, but I don't want to let the opportunity to circle back to comments that were made earlier that recognize moral injury to people that are service providers who see needs going unmet, who see patients going unserved, and who also see colleagues that are struggling and struggling with that moral injury themselves. And this is something that we are an ACC, which is a training location for some amazing nurses and other allied health professionals, and that is something we absolutely are working on. And I'll let Cynthia address the concrete first, and then leave some space for Dr. Mullen to talk about the national picture.
So I wanted to add a couple of things to that, just because as you were sharing that, one of the real life examples that came to mind was we currently have an employee that's part of our navigation center who is a single mom who works part-time so she can go to school part-time so that she can move forward from a medical assistant into becoming a registered nurse. And one of the original thoughts, and that my colleague and I are constantly trying to figure out, are like, how do we continue to remain flexible with those that are trying to pursue these careers? And so to answer your question, like, just people to consider, it's like, be flexible, meet people where they're at, see what we can do to help grow these individuals, and not set them up for failure to where it's not an option. So that's one of the things that I can share. And then the second thing is, I think one of the steps that we are currently taking outside of the community health workers, not internship, but a program for students, is around medical assistance, right? You need to start somewhere, really trying to make sure that we're helping them get the experience that they need. But once we're done with that, we're going to be moving towards nursing, right? We're going to be moving towards not just nursing, but also healthcare administration staff members, right? Like, how do we continue to promote and create an environment where people can have, I guess, a platform to practice, to be supported, to be like an incubator so that they can go and do good for the community, right? So those are just a couple of thoughts that I would share.
So we could spend at least the whole morning on your comment and observations about another problem with our low-functioning non-US healthcare system. One in which many would say prevention and primary care are not valued. They're not prestige specialties. And so I'm talking about pediatrics, I'm talking about internal medicine and family medicine. I'll even throw behavioral health in, nursing. We have the issues around education. We have issues around where people's hearts lie, and the way medical training sometimes erases the heart to care for people and care for humanity out. I mentioned a little while ago that about 20 to 30% of care providers care for about 80% of the safety net. A larger percent of racial and ethnic minority care providers are in that 30%. Some people have thought, well, train more people who look like the community. Well, then we have legal policy and anti-affirmative action policy and on, which has been undone, but even in the context of it, we didn't have the increase in diversity that we needed anyway. I think I read a statistic that doctors' kids are 20 times more likely to end up in medical school. And I don't know how many of their parents are telling them, when you finish, go out and take care of the community. So, I mean, I'm just touching on little things for people to think about. in our system where, you know, Dr. Jocelyn Elders also said years ago, we don't have a healthcare system, we have a sick care system. So as we look at this plan, it becomes extra challenging to know that part of what has to be prioritized in these initiatives might look like sick care, but that's because there's been even less ability to put the sick care system in place where primary care hasn't been able to emerge the way it needed to. And Dr. Zambrano, do you want to add anything?
I think one big elephant in the room is that we're coming off the heels of a pandemic. Healthcare workers have really been through it. My background is hospital medicine, and I saw a lot of colleagues and other ancillary staff that just said, I just don't want to do this anymore. And so part of it is rebuilding and recovering and having organizations that care for their people so that people say, okay, I do want to come back into the workforce. I think the other key piece of this is utilizing what we have. So as we're sitting through our meetings and we're coming up with our plans, we ask the question, who can do this? A nurse doesn't have to do all of these things. We can utilize our health workers, our community health workers. So part of it is just being smart and strategic, utilizing what we have until we can regrow that force.
Take a couple of quick questions.
Thank you. My name's Bella. I've worked at Community Care, Elwyn, used to work at a platform that connects people to social care, and now I'm at the food bank. And so I'm really interested in the social determinants of health. I know it was one small widget, but obviously there are many other widgets connected to it. And I see it's up here as well. So I was wondering if you all could talk a little bit about what you're currently doing around social determinants of health, but then in this plan, within those 38 initiatives and projects, if you could just speak a little bit about kind of how you want to incorporate social determinants of health, and then, you know, are you all thinking about creative partnerships with people and organizations in the community? Like, what's going to be your approach to that?
Thank you.
I'll kick us off. We talk about social determinants of health on the daily, and I'm kind of looking at my colleagues here because it's every day, and it's anything from we're working on a workflow and building it in incrementally. It's working on scripting, building it in incrementally. We're currently working or just executed a contract with this resource database, right, so that our staffing have the tools and resources available so that they can inform patients. Once again, scripting, letting them training, creating the training material behind it so that they know how to use it appropriately, and then challenging ourselves to ensure that behind that tool, there's actually something working, right? And that we're testing those pathways down instead of just saying check. So from social determinants of health currently, I can share that, you know, I think one of the lower hanging fruits is we have had transportation available for our patients. That is something that we have had for a couple of years now and that we continue to really put at the forefront because that is a serious barrier for the patients that we serve. And so outside of that, it's really leveraging a lot of the staff members, social workers, making sure that they are currently available to help connect patients to resources. So that's a couple of items that I can add, and I'll pass it off to Monica.
And I would say we've got kind of this larger, as with everything, this more patient person in front of you aspect, and then this larger planning aspect. And I think the planning aspect, I know Elizabeth Moreau is now here, and so as we're designing facilities, I know that Ted had mentioned the new health centers that are opening up in Hornsby Bend and Del Valley. And if you look at the health centers as they open up, it is trying to make sure that, you know, we've had, I think, collaborations with the food bank and a community kitchen at Southeast Health and Wellness Center, trying to make sure that there's access to, you know, healthy food and kind of farm to markets, that we are partnering with other community organizations. We often partner with WIC. We try to, we've got programs partnering to ensure that there are feminine care products and diapers and things like that So we do we do now, and we want to make as part of this larger plan, collaborating with the social services groups that are the expert providers. This is something that we're also looking at in planning for how will best address healthcare services in new supportive housing that's being opened up over the years. So working with, not trying to step on, but really truly collaborating with the expert providers, and then also talking to patients that we serve as they're coming into care and trying to determine what the barriers they're facing are. And so it's discovering things like pharmacy copays, things that really the patients that we're serving are facing as barriers, and taking steps to try to make policy changes when we can to address those barriers.
Thank you, Monica. We're going to take one more question, and then we're going to move on. I'm going to have a question here, and we're going to talk about how we're going to phase in these initiatives and projects. And then some of you may have been wondering how we're going to pay for it. So we'll talk about that next as well. Steve?
Thank you. My name's Steve Swanson. I was touched by two comments, one about the gentleman reflecting upon the need, that there's needs out there and he doesn't feel like anybody knows it. And I think he's gone now. And then the one about physicians, nurses not being attracted to and leaving the profession. And I want to share with you, I'm a 30-year public education advocate, volunteer, that includes last fall a hearing at the House Education Committee where they were worried about where are our teachers. In the last 6 months, because of my own personal circumstances, I am now thinking about where are our nurses, where are our doctors, and why aren't they there? So I testified, cast light on existing law and the importance of attorneys and the Texas Lawyers Creed and the existing laws that exist in education. They also probably exist in healthcare some way. They exist in the Imagine Austin plan, to bring people together to solve problems and know that you're doing it. Lawyers are important, and the creed is important. Lawyers' creed. The lady who spoke after I spoke, eloquent person, teacher, she came to this place where she said, in 2020, I was one of them. This is pre-pandemic, by the way. I was one of them. I was one of the teachers that left teaching. And then she concluded by saying, when her family and friends asked her why she left, she said, I love teaching, but it didn't love me back. I love to care for the health care of people, but health care doesn't love me back. It is systemic. And until you develop the relationships in front of doing the projects that value trust and respect and open and honest conversation where love and care and respect for one another permeates it, and in addition to 150, I would include work plans, step-by-step action that you can show the public. So instead, just a strategic plan, which we do a lot of in education, they're all over. But what happened afterwards? Sits on the shelf. Each of those projects needs a step-by-step work plan of who's going to do what by when and how are we doing, evaluating whether it's getting done to save and nurture the lives of people.
I think Steve was paid to set up the next piece of this conversation, which is how are we going to get this done and what is the timeline? What is the actual work plan? So it may look like a lot. We'll talk through this. But this is the phasing for the next 7 years. We'll be back here in 2030 in this room, same date, same time for a community conversation. Everybody sign up and commit to being here and hold us accountable. But Monica, do you want to start by talking about, or is it Cynthia? Cynthia, do you want to talk about the phasing for the development of, or the implementation of this healthcare equity plan?
I'll add a couple of thoughts before I pass it over to Monica. But really quickly, what this chart does not show is the work has started. And I think we've alluded to that. I think one of the best examples on this slide would be the robust post-acute care, also where we've tucked in the medical respite work. We have started creating the teams that will help launch us into the direct practice space here. And we've got one of our team members here in the back. Thank you, Dakasha. So that's one thing, like this is not capturing. Now, to answer kind of, Ted, where you're headed is kind of how do we get this all done, and what thought has gone into how we have put here on this really nice picture, how we're gonna roll this out. You know, this has been a real important exercise for the organization as a whole to be going through, in which I think Monica kind of mentioned this earlier. We've had to self-reflect and look at what are the internal capabilities, what are our resources looking like today, and then obviously put where do we want to go and when, and then how are we going to close those gaps. And so if you were to ask me, how did we start structuring this and putting a path forward, it would very much be that we've reflected and we're starting to understand what is it going to take in order for us to achieve what it is that we are here today telling you that we would like to set out to do. So with that said, I will pass it to Monica to kind of share a little bit more information on the design of this.
And I would like to, we have Cynthia, we have Melinda, we have Jewel here. We've got our data and analytics director, Sarita Clark-Leach here. We have folks from the finance team. For every single one of these things, that it's a line or a star or a project or initiative, we have people that are a team of folks who work on contracts and working with folks who provide contracted respite services or contracted health services. I notice Regina Rogoff from People's here as well. I've got Susan Millay from the United Way. We have teams of folks that work with our providers, as well as folks who work on these direct service initiatives. And so for every one of these projects, there are workflows, there are plans, there are financial plans and phasing that goes behind them, as well as Yvonne and and Ted and the communications team that helps us do events like this, who also does, you guys do direct outreach. You've got your community health workers who are also directly in the community, gathering feedback. And so that is part of the development and implementation of these work plans. Access and expanded access for primary care, dental care. We've got Del Valley Clinic, Hornsby Bend Clinic. We've got clinics opening at Hancock Center, which is the old Sears, coming in over time. We have significant work that's going on now leading up to these projects actually coming online. When you look at this slide, there's light blue work. So there's light blue work, which represents kind of ongoing foundational work that we have teams working on, working with community partners and working on directly, constantly in areas such as pharmacy and pharmacy optimization, making sure that we're looking at copays, at prescription assistance, at making sure we've got the best formulary to serve people that need care, and also that we have availability of pharmacy services in all across the community, and also delivery services. So ways that we can get prescriptions to people. We have constant work going on in enrollment and eligibility, in building out data integration. So working on things like the SHIP program with community partners, and also making sure that our data infrastructure is secure, and also that people can access their health records when they need them. And then the dark blue lines represent work on projects like the new clinics, like some process improvement work on things like support of same-day care and expanded hours, or some of these substance use projects. And then also there is ongoing work in areas like Standing Up Rosewood Zaragoza, access to specialty care, post-acute care. So some of these projects will take a number of years to actually come online, but we've begun the work now. Some is kind of constant work, and then some, we're close to actually bringing online in this coming year.
And if you registered, online or here at the event, we are going to email you a copy of this presentation. All of this information is always available on our website, centralhealth.net. And if you reach out to us individually, we'll be happy to share information with you, sit down, have a conversation, and listen to you. So you don't have just like one shot to have this memorized and walk out of here a healthcare delivery expert. Although we could think about a test, but we won't. So let's move to the next slide. How do you pay for this? Obviously, this is a lot of very big visionary projects, and we will talk about the budget. I see somewhere in the back of the room, perhaps, our deputy CFO, who's here as well, who I might be able to put a microphone in front of. But let's do, Monica, talk about this, and we're going to look at over the next 7 years and what the financial implications are.
And I am not a finance expert. I have to use my fingers when I am counting. So, please take this for what it's worth. I think the key point of this slide is, and these are incremental estimated operating cost. So this is on top of expansions in contracts that we already have that are built into our annual budget forecast. These are dollars and estimates that are tied just to the projects and initiatives that we are discussing today. One of the reasons that we are phasing these in over time is it takes time for us to have the dollars that it will take to fully fund these projects, and building out this financial sustainability over time is a key part of being able to be successful in standing up these projects in a way that they and programs in a way that they become part of this high functioning system over time. And there is more detail, and I know I'm not trying to get ahead into the next steps. This is very high level. Every year, the board passes what is Central Health's key policy document that drives our work. These plans represent this higher level approach, but every year during our budget season, the Central Health Board of Managers passes our budget, and then of course that's approved, the budget and tax rate are approved by the Commissioners Court, but there is a higher level of detail about the work, the projects that are approved each year during the budget season, and there are going to be more conversations and presentations about that coming up as well.
We also have some flyers in the back of the room with information about upcoming budget community conversations. I would also like to add that you may have heard from people in the community or other organizations that Central Health is sitting on a war chest of reserves, $400 million. The reason Central Health has reserves is because we have to plan for the future, which we're doing now. And so those reserves are strategic. It's our obligation as responsible stewards of your tax dollars to build and maintain adequate reserves to pay for healthcare expansion. And we're happy to talk about that as well. Anybody have any questions about this? We're going to move in and talk about how all of the things that we talked about this morning, and I promise we're getting near the end and we want to leave room for any more questions or comments, but how all these initiatives and projects will shape next year's budget. We are actually in the process of building our fiscal year 2024 budget. Monica mentioned our Board of Managers approves our budget and tax rate. Ultimately, it's Travis County Commissioners, your elected officials, who will approve our budget. So anybody have any questions before we move on? Questions? It's a question, right?
Do you guys know if the money that you are using, that the healthcare, I'm not going to speak to you specifically, but in general, the healthcare system that it uses is serving the needs of people? And I can reflect upon that from education, because in education they talk about funding and they don't talk about whether kids' needs are being served.
That absolutely is part of this planning process. So part of this planning process is continuing the development for each of these initiative areas and projects of key performance indicators and measures, looking at both, to Dr. Mullen's point earlier, process level measures that we can count at intermediate outcome points for things like impact on markers based on illness and measures of health, and then ultimately looking at these longer term overarching health outcomes. One of the things that we do every 2 years across our system is look at burden of disease, and this burden of disease geographically and by different demographic factors that we can really look at over time every 2 years. We also have, as part of our contracts with contracted providers, measures and reports that they have to provide us. So that is determining, is not only is the need being met, but are the programs that we're implementing to try to better meet the needs. We know already that the need is not being met. And so what we need to look at is, how do the projects and programs that we're implementing, are they moving us towards better meeting those needs? Absolutely, thank you.
And we also undergo an independent outside performance review every 5 years, and that will be taking place later in the fall, most likely. So, and we will report out on those findings as well.
Can I
Yes,
say
please,
something?
please.
I hope that as people look at this and think about investments, they keep in mind that to make these investments pay off for the best, and I know everybody in here gets this, other stuff has to happen in the Austin or the Travis County that Seth Dockery asked me about earlier. Continuing to try to improve a healthcare safety net has to be coupled by continuing to create a community that supports health in all the ways that people asked about, social determinants and others. And in addition to that, not necessarily being what all of this healthcare safety net stuff is about, people who are happy to be here have to keep listening to news like somebody else got killed trying to cross a highway today, last night, because of an inadequate infrastructure. And I don't know how many people aren't getting the energy assistance they need in this heat, and on and on and on. And so I'm very mindful of what it's like to be glad when there's visionary thinking on behalf of a population But for this community to be healthy, we have to invest in education and teachers and all the rest. And so the measure of success here is going to be challenged if the rest of the social safety that continues to fray. And we're in that circumstance right now. So it's not election day, and it's not just about vote, but that's really, really important.
Thank you, Dr. Mullen. Let's look briefly at this last slide. Really represents our budget priorities for next year. You really heard about all of our priorities, but at a glance, these are what our board and our staff will be focused on, and this is what the money that you invest in Central Health will pay for. Cynthia, do you want to take this one?
Hello, okay. We're gonna go and do the work. I think this fiscal year has really been kind of setting the stage and building some of the infrastructure, and we're really gonna put it to the test this next year. So that is in the areas of launching our RZ, Rosewood Zaragoza multi-specialty clinic. And we're also gonna really bring to life the transitions of care work that we've been sharing, that a lot of it has started to be built this year. Next year, we're really gonna enter into what Dr. Z was referring to as far as placing central health providers in the skilled nursing facilities to do the work. This is really some of the areas that we're gonna be prioritizing alongside really moving and ramping up our medical respite. As far as the care coordination goes, we are going to go launch our electronic healthcare record system to support all of these different areas. This is stuff that we have already started doing, and now we're gonna go and do it, and then we're gonna test it, and then we're gonna improve it, and then we're gonna keep doing it. And so we're going to finish building a navigation center, which we have started doing this year, incrementally taking steps to not perfecting it, but definitely being considerate of all of the moving parts and the social determinants of health that we're hoping that the center can help address. As far as member engagement, definitely want to increase MAP enrollment. We want to make sure that we come to the patient and from a virtual standpoint, make those services available, as well as, once again, from an electronic health record standpoint, we want to make services such as MyChart available to the patients so that they have a mechanism to be able to continue communicating with their care teams. And then lastly, from the system of care infrastructure, I mean, we're building it. We're building it from the KPIs, from oversight over all of these programs that we're looking to get off the ground. We are building the clinical practice infrastructure that has not existed today. You're talking even the policies and procedures that have not existed today. So this is everything that is going to carry forward into our next fiscal year, alongside bringing in the people that are going to help us do it. So.
Thank you, Cynthia. We're gonna wrap up. We can take one or two more questions, and then our President and CEO, Mike Geeson, will have a couple of closing remarks. Before I take this last question, I do want to thank again the venue, ACC. They've been a great partner, the caterers, the AV folks. It's been seamless, and we really appreciate all that you've done. We want to thank our ASL interpreters. I get distracted because I'm so busy watching them and as they tell the story, and so we are deeply grateful for them being here. Our Spanish interpretation, you may have heard someone talking in the background. That's because we're offering this community conversation in Spanish, so we're always grateful for their assistance. Kelsey Creek, I hope you were here early enough to hear Kelsey Creek perform. I'm a fan. I'm going to stalk her now on Facebook and Instagram and everywhere else. But thank you, Ham. They're also a great partner, and we appreciate them bringing music and bringing life to the meeting. And again, we'll share the PowerPoint, the information. Please stay connected with us. We hope that you will follow us on social media. We're very active. This whole thing has been broadcast live with commentary, and so we hope that you will follow us on social media. Sign up for e-newsletter updates. Join us for community conversations. We have several coming up in August about our budget. We want to hear from you. We want you to be not only part of the conversation, but leading the conversation. So thank you so much for being here. Let's thank the audience before we thank our panelists. We'll take one more question, and then Mike, I'll turn the microphone over to you.
Thanks, Ted. One program that I haven't heard mentioned is a very active and vibrant program connected to Central Health, and that's the Central Health Equity Policy Council. I've been a part of that group since, I don't know, a long time ago, and that Megan Cermak, who was here, I don't know if she's still here, she oversees that group from Central Health. And when we think about sort of advocacy and moving the needle and really, creating a more vibrant and a vibrant safety net, I think these initiatives that the Policy Council addresses help to address some of these things. It's overwhelming and there's a lot to do. But since we've been part of the council, I think we've had an e-cigarette ordinance that was implemented, school recess policies that were implemented, increasing HIV testing rates. We're currently working on one right now that's advancing LGBTQIA equity in our clinics and our hospital systems, which is really important. And the work is long and it's overwhelming, but I would say that that's one meaningful way to become involved in the work that Central Health facilitates with community partners. So get on the website, Central Health Equity Policy Council, we call it the CHEP Council, as ways to get involved. Again, to make it a little bit more manageable and ways to get involved in the work. Thank you.
Thank you so much, Brandon. And that absolutely is when we look at how to address social determinants, this is something, and as Dr. Mullen said, I think the work of the CHEP Council is an example of doing the work you can, where you are, making a meaningful impact, both in policy areas, social policy areas that have this way upstream long-term impact, and now in healthcare policy, direct clinical policy impact. So, I think that when you go to conferences across the country, the Healthcare Equity Policy Council type work, that way upstream work, is something that hospital systems are trying to do all over the country, and you guys are, we are collectively doing this here today. So thank you so much, Brandon.
Thank you all. I was asked to provide some closing comments, but how in the world do you close out a conversation like this? You really can. In fact, you're doing everybody a disservice if you do close it out and say, oh, okay, we're done, now on to the next, shiny object that we chase after. But really, it's about all of us going out there and being ambassadors and keeping this going, but also coming back and having these conversations, because I heard a phrase earlier, and it was, we're gonna come back and revisit what we're doing to make sure that not only directionally, but by very precise means, we are alleviating healthcare disparities. We are bringing about health equity in people's lives. Ideas are great. It's fun to have ideas because you can just sit there with just no computer, no pencil, no anything, or paper, and you can just have ideas, and it's fun to talk about them, and you need to do that. That's part of the human experience. Ideas are dessert for the human mind. We need that kind of snack. But what really motivates us is the work of the hands and the heart. That's why we're here today. And on behalf of everybody at Central Health, thank you for staying here with us today. This has been a great audience. I mean, you're 80, 90% here, which it shows that this was compelling, and we hope that it was. Thank you for those that joined us on Facebook and are still with us. Again, these are very important conversations to keep going. We're not going to close this out, and we'll look forward to when we get to talk again. Thank you.